Good afternoon. Welcome to this Hfma webinar, Modeling and Managing the COVID-19 Recovery, sponsored by Ensemble Health Partners. It is my pleasure to welcome today's speakers. Pieter Schouten is Chief Analytics Officer with Ensemble Healthcare Partners. Pieter has developed a comprehensive set of healthcare analytics solutions that integrate with existing technology infrastructures and drive significant revenue, cash, and cost improvements at leading healthcare companies. His expertise includes advanced analytics, development and deployment, cognitive computing, software innovations, analytics IP development and patient protections, and data science, team building, and leadership. He received his BS in Commerce from University of Virginia and earned his MBA from the Harvard Business School. Eric Nilsson serves as the Chief Technology Officer for the SSI Group, leading SSI's long-term technology vision. He brings 30 years experience in the software industry with the last in AI and machine learning to bring new meaning and actions to data as well as delivering mission-critical solutions that power the healthcare continuum. He received degrees from the University of Toledo with a degree in business administration and computer systems. Eric serves on the University of South Alabama's boards for the School of Computing, advisory board member, and the Center of Advanced Research in Forensic Science. With that, Pieter, I'll turn the presentation over to you.
Thank you, and good morning to all. The past few months have been unlike any that we could have ever imagined. COVID-19 certainly has hit the economy and especially hospitals very hard. Today, we'd like to show you our analysis of what's happened within the hospital industry and what we believe may happen going forward. So we're going to address a series of questions through our data analysis that are listed on the slide. I'll kind of walk through them. How steep and far-reaching was the decline? What's the current status? What may recovery look like? What do claims, revenue, and scheduled data tell us? And how can you leverage this information? A few months ago, I started talking to Eric Nilsson at SSI, and we're just comparing notes on what we're seeing in the data. They're looking at it from a claims and eligibility perspective, and Ensemble was looking at the data from a hospital revenue and cash and scheduling perspective. So we started comparing notes, and we saw a lot of similar trends and also some differences. So we decided to formalize our collaboration and see if we could track the trajectory of the decline and the trough, and then ultimately the recovery, and really with the purpose of sharing it with those in the industry that are all affected by this to see if we could make a difference. Ensemble is a leading revenue cycle outsourcer with $17 billion of net patient revenue under management. And SSI is a leading revenue cycle technology solution provider who processes over 1.2 trillion in claims annually. Together, we serve more than 2,500 healthcare providers, so we have a healthy slice of the market, and we really complete the picture through looking at revenue and cash collection data, scheduling data on the Ensemble side, and then claims data and eligibility data on the SSI side. Now let's look at the sources of insights that we are bringing together today. We really gained insights from 7 areas and then combined them into one overview and analysis. We looked at claims data, eligibility data, hospital volumes, hospital revenues, hospital market share, and the combined with the COVID surge models, patient scheduling, and then of course state rules and regulations around lockdown and other procedures within hospitals that are allowed. Let's look at the data analysis in more detail. All the data was aggregated and anonymized before we did any analysis. SSI created a consolidated weekly claims and eligibility data view, while Ensemble created a scheduling and revenue data view. No data was combined across the companies, only the trends were analyzed. With the combined trend, a more complete picture emerged, which we're going to share with you today. We did use some modeling. We focused on Hfma modeling, but really this exercise is less about modeling and more about looking at data and determining what trends are emerging and sharing that with you. I will now turn it to Eric to discuss the analysis, starting with the decline phase.
Thank you, Peter. This is truly an unprecedented time in the healthcare industry. We've all had to react and change our approach to how we operate to address this crisis. And one of the questions I'm asked by our customers is, how is this decline for our hospital compared to other hospitals of our size and type? And what does the recovery look like? And that was one of the reasons that we partnered with Ensemble, was to work to answer these questions. Let's first take a look at the decline. The decline that we saw overall initially over the last 8 weeks has been in the area of 40 to 50% in overall net revenue and patient volume. There's many factors that go into that. The state factors, the shelter in place, restrictions on elective procedures, and the extent and speed of the COVID-19 spread has also affected this. We also looked at the patient mix of inpatient, outpatient, and emergency, as well as the mix of elective versus non-elective procedures. And how we did that is we looked at 4 major areas: claim volume, eligibility volume, net estimated revenue, as well as scheduling data. Now let's take a look at the actual the decline curve. This 30-day curve is a 48% decrease in just the 30 days. It's by far the largest drop we've seen. The curve here is a 7-day moving average of EDI 837, hospital UBO4, and physician 1,500 claim volume for more than 2,400 providers, of which 1,200 are hospitals. These hospitals are made up of large multi-state IDNs, regional IDNs, rural and community, along with large physician practices. Now, while we do see some seasonal variations around major holidays, nothing of the scale and time duration have we seen since we've seen with this COVID pandemic. We just haven't seen anything in the 30 years we've been in business. The decrease paints a picture of our nation canceling elective and non-emergent procedures and sheltering in place. Let's take a look now at the eligibility curve. On the eligibility side, it was a steeper decrease at 58% in just 40 days. And there's a high correlation between eligibility and the claim volume we'll see. Typically, eligibility is a leading indicator and claims are a lagging indicator. This represents our EDI 270 eligibility requests made from the initial service request. The decrease started March 7th compared to claims that started on March 10th. And as I said before, we see a high correlation between the movement of between eligibility and claims. We'll examine that a little bit later as we look at the recovery and what might be the leading indicators for that. Now I'm going to hand back to Peter to look at the revenue and scheduling side. Peter?
Thanks, Eric. A number of states did not issue a stay-at-home directive, and so we were interested in looking at claims trends for those states versus the other ones. The states that didn't issue a stay-at-home directive included Arkansas, Iowa, Nebraska, North and South Dakota, Oklahoma, Utah, and Wyoming. So we looked at outpatient claim volume declines to see if there was a difference for these states versus all the other ones. And we noticed that volumes declined at a similar pace, although the bottom was less deep for these states by about 10 percentage points. So then we looked at inpatient claims trends for these states versus the other ones to see what the trend was, and they showed a similar decline story for these states, although the gap here at the bottom remained 14 percentage points instead of 10. And non-elective inpatient claims remained flat in the non-shelter-in-place states, while they declined 8 percentage points in the shelter-in-place states. So let's look at hospital revenues. Hospital revenues across the systems in our data pool declined by 43%. Those declines were led by outpatient and ER revenue declines, which were 58% and 53% respectively. And inpatient revenue declined by 27% for the hospital systems that were in our data sample. In addition to the revenue picture, we wanted to look at scheduling as a leading indicator. And scheduling data showed a 52% decline in volumes. In addition, the average scheduling time to the appointment tripled versus the normal appointment window. So in the top row, you'll see that the average weeks out goes from 1.1 to 3 weeks, or 2.9. So that was a pretty, in addition to the volume decline, there was a pretty telling picture, and you can see sort of the red to the left disappearing from the picture as appointments get scheduled out. In summary, the decline that we've seen was very rapid and deep, and the data is very consistent between industry claims, hospital revenue, and scheduling data. I will now turn it back to Eric to introduce the recovery phase analysis. Eric?
Thank you, Peter. Let's look at the recovery. We are beginning to see a recovery in all four of those factors, and one of the things that we're going to examine here is where are we and where was the low water mark. So let's dive right in. There's a number of things that affect the recovery. There's internal factors and external factors. Internal factors are things that we can control to a large extent as we run our healthcare systems today. Things that include, patient mix, case mix, access, hospital capacity, COVID guidelines. Things that are outside of our control are what is the spread and decline rates or increase rates of COVID as it goes through the United States. Shelter-in-place regulations as they begin to ease, state regulations on elective procedures, approach to opening the economy. It's mandated through the state and the county levels now, so it's very local, hyper-local. Social distancing guidelines for hospitals, and then, ultimately, how are we doing on finding improved therapeutics as well as vaccines for the COVID crisis. When we look at the initial recovery in the claims volume, we're seeing an 18% increase since the low water mark of April 17th. And we're continuing to see this increase with the claims volume as we watch it on a day-to-day basis. What we're looking at on the next slide is the recovery of Monday claims. Monday is historically the largest volume day for claims to be processed across the country. And it's one of the indicators we look at. We've had 4 Mondays in a row right now where we've seen increases, and that's a good trend indicating we're starting to move through into a recovery phase. When we look at the eligibility side, we're seeing an increase of 45%. Remember earlier in the presentation I indicated eligibility is a leading indicator and claims tends to run about a week behind from an eligibility request, and we're seeing that in the 45% range. When we put the two curves on top of each other, we can actually see this interplay between eligibility requests and the claim volume about a week post increase in eligibility requests. And
Thanks, Eric. So as we noted earlier, hospital revenues in our sample declined very rapidly. The average was about a 12% decline per week in our data set. So we wanted to see what kind of pickup are we seeing, what kind of recovery are we seeing, in addition to the claims data that Eric just reviewed. So since mid-April, we've seen hospital group revenues in our sample rise about 8% per week, with the exception of some hospitals in the Northeast, which obviously had more of a COVID surge than others, and that continues to have an effect. So the challenge with these numbers, 12%, 8%, 12% decline and 8% recovery, is that the recovery is on a much smaller base because now you're at a half of what you were before. And so if you do the math on that, barring any other unforeseen issues, such as reaching max capacity or another COVID spike, the math says that the recovery would take about twice as long at a minimum, based on this recovery rate and based on the lower base that you're starting from. So let's look at scheduling data again. Scheduling data shows a recovery both in terms of volume growth, but also an emerging return to normal for the average weeks out. The heat map on the left shows a gradual return of weeks out by the increase in the red area to look more like the before picture on the left of the heat map. And then the graph on the right shows both the volume rise and in the columns, and then the line in the chart shows the return to average weeks out. That's a little closer to the pre-decline phase. So I think the absolute percentage increases will, of course, differ by hospital, but the trends are interesting, and hopefully they're helpful to you as an early indicator of what is happening. So based on our analysis, we're forecasting a recovery that is not going to be V-shaped, unfortunately. It may be U-shaped, although it doesn't really look like a U. It definitely isn't L-shaped because we are seeing some recovery. So to us, the recovery right now looks more like a Nike swoosh, or it could become a double Nike swoosh if we see another COVID surge that leads to a decline. And the recovery timing is very dependent by state and driven by state regulations and when the states decide to open up. So you can see some of the early states that we've mapped here already showed a recovery, and then some other states will be delayed and continue to be delayed. So depending on the individual regulations and decisions by state, that's going to determine the timing of the recovery. We also don't expect a full recovery to 100% in the near term, and there's really 2 factors that have an influence on that. One, we think there will be some limitations on capacity as social distancing rules will continue to be in effect, and they will have some impact, a continued impact on hospitals and how they are laid out and how many patients can be served within the existing facility. And the second impact is more of an overall economic impact. When we look at and consider the overall economic forecast, we'll continue to see some depression of GDP well into Q3 and into Q4. So we think that also will lead to a cap. In our model here, we assumed that the recovery is capped at 85%. It might be 90%. We don't really know. Time will tell. But there will be some cap to which the growth will be limited. So a few closing thoughts on how you can leverage this information. I just talked about capacity, and that's going to be a critical factor going forward. Careful planning and analysis on capacity by service line is going to be critical to managing the recovery well. And as demand ramps back up, supply within certain service lines will become a critical bottleneck. So hospitals will have to plan accordingly and be flexible in terms of moving capacity and adjusting capacity to where it's needed the most. Since the recovery shape is likely to look like a Nike swoosh, you should manage accordingly, because it means that a slow recovery will dictate containment of expenses for the foreseeable future into Q3 and Q4 at a minimum. Thirdly, it's also really a good time to look for and find money in the seat cushions, as we call it, by revisiting every part of revenue cycle. And I've listed a few items here, and we've done separate discussions and webinar recently on that topic. So I'm not going to go into all the detail, but every part of ref cycle is important. Nothing should be left untouched. It's really a time for back to basics and look for every dollar that you can recover within your revenue cycle. And then I'd like to end with some thoughts around the use of technology and innovation to improve revenue yield. Now is a great time to try to leverage technology and squeeze out every dollar we can. After cost savings plans are in place, it really is a great opportunity to deploy intelligence and automation to improve revenue yield without increasing cost. So I listed some examples and areas that you could look at to drive results. Schedule optimization is obviously important right now with the capacity constraints and trying to move the different service lines capacity. DRG validation, just looking for outliers and trying to re-examine DRGs that need to be potentially recoded or should be sent to physicians for a query. Charge capture, looking for missing charges. AR follow-up, just re-ranking the AR. These are just some examples that you can look at. You may have other ideas. You can start. They don't have to rely on expensive platforms or very long implementation cycles. In a lot of these areas, you can start with simple rules-based solutions to look for outliers or misses, or in the case of AR, find ways to re-examine small balances or re-rank your AR based on expected value, which can be done with a simple segmentation, looking at, if it's this balance and here's the age of the AR and this payer has typically paid this much. You can re-rank AR pretty simply versus just looking at balances only. So these are some examples. I hope you found this information useful. I will now turn it back to Glenda for some question and answers.
Any projection on how much of an impact the increased unemployed, uninsured rate will impact revenue?
So that's a good question. I think the general
economic picture will have a depressing impact on revenues, and the when I look at GDP forecast, I think the consensus is that we're looking at well into Q3 and Q4 there'll be some depression, and not until 2021 will we be operating at full speed, and I assume that the unemployment rate will sort of track along with that. Eric, do you want to add anything to that?
Yeah, one of the things that we've been looking at, we don't have any data on today, is CMS with the uninsured COVID claims are now coming through as claims within the systems. We haven't, again, we don't have anything to share with you, but we are now starting to see that data flow through. That should help alleviate some of that. But as a whole, it is something we're looking at.
In states that did not have shelter-in-place orders, did the hospitals follow the same limits on elective services per state or Nation Hospital Association?
Yeah, it looks like when you look at outpatient trends, it does look like the elective surge, the elective procedures showed a similar decline, although the bottom wasn't as deep as the states that had the shelter in place. But there definitely was a decline, and it's safe to assume that it's because elective procedures were canceled.
I love the visuals of the potential recovery sceneries. Can you tell us which application you used to create them? They appear more sophisticated than Excel.
Yeah. No, actually, there's nothing fancy here in terms of graphics. Your typical Excel and PowerPoint did the trick. But thanks for asking.
Next question. Are you seeing any recovery modeling that would include insights on revenue losses or recovery strategies for value-based care contracts that are largely reimbursed based on quality measures, STARS rating associated with successful, timely completion of preventive screenings? Many of our Florida patients over 65 have not been able to get these done and will be leaving the care services area during the summer months.
So maybe Eric has insights on that, but I mean, for our analysis, I looked at the numbers more in the aggregate. I'm sure there is specific information there pertaining to your question. I just looked at aggregate numbers and trends for this purpose.
I'll second that, Peter. We also looked at it in aggregate.
Okay, next question is, how would you recommend the healthcare system use the funding levers available due to COVID impact to their revenue cycle?
Well, I think you have to get every dollar that you can get. The decline has been, unprecedented, dramatic, and I don't want to say catastrophic, but definitely extremely challenging. So to the extent that additional funding is available, that is absolutely mission critical, including, but in addition to that, some of the basic revenue cycle, going back to basics, examining small balances, doing everything you can to find the money in the seat cushions, I think now is critical. And where we see volume declines and maybe have some extra short-term capacity, we sort of redirect some of that capacity at re-examining things that could provide additional yield.
To prepare for the COVID, did hospitals overstock on medicine and supplies And with a slow recovery, how do you see that playing for the next 6 months of purchases?
That's a good question. I'm not sure I can answer that. I'm sure there was a lot of planning involved, and that was critical to hospital serving their patients. It's just not an area that I'm really focused on.
How would you recommend that healthcare systems use the funding levelers available due to COVID to impact their revenue cycle?
I think that was the same question as we had before. I think you should take every dollar you can get to improve revenue yield at this time.
When there is a second wave, will the declines be the same, or are the systems learning how to adjust to care for COVID as well as continuing scheduled services?
My prediction is if there is a second wave, it's going to be probably more state specific, and I would imagine that each state will track their data more closely, and while we saw a collective nationwide response for the initial wave, nobody knows this for sure, but my guess would be that for a second wave, every state will look different, where some states will not have a second wave and others may have one. So I see more of a regional impact there. Eric, any thoughts on that?
I think you're correct as well, and I'd probably add we've learned how to live with the virus over the past couple of months here, and as we go forward, we'll have more tools in our toolbox to be able to combat the virus, and I think that's going to allow us some strategies across the country that's going to allow us to continue to move forward with our healthcare.
Does your analyst include telemed claim changes?
Here, I'll take that one. It does, and we're actually seeing an increase in telemed claims, something we're studying as we see these claims go through our systems. There's been a very dramatic increase in telehealth claims over the past 6 to 8 weeks.
Do you see healthcare systems bringing back all of their revenue cycle staff that they furloughed, laid off, if revenue isn't going to be back to previous levels, or will they utilize technology and utilize less FTEs?
I'll take that one, Eric, and you can add to it. I think that this will be a prolonged recovery, so we have to be efficient and do more with less, which means focusing on the right areas, using technology, trying to use automation, trying to use analytics where we can. I think that will continue for an extended period. Eric, do you want to add to that?
No, I agree. It's going to be a few months before we really get any sign on what we're going to, how that recovery is going to look from bringing people back and what the overall hospital revenues look like.
You shared that the recovery will take twice as long as the decline. Is your modeling showing the new ceiling will take about 60 days from mid-April to achieve the new ceiling?
Yeah, that's a good question. So it depends on the state, right? For the states that are opening up early, that seems to be about right. Although, we're still hoping for, and Eric and I were talking about that this morning, we're still hoping for some sort of an acceleration or maybe a hockey stick, although we haven't seen that in the data yet. But it'd be interesting. We want to track the early open states closely over the next coming days and weeks to see if we see such an acceleration, but so far we haven't seen it. So I would say yes, that seems to be based on the data. Based on the data that we've seen so far, that seems to be a reasonable estimate. Of course, the 60 days, the start date will vary by state. with states like New York being much later than other states.
Peter and Eric, do you have any closing remarks?
Well, thank you everybody for dialing in. It's been a really fun initiative. I'd be happy to entertain any follow-up questions or ideas that you may have for further analysis, and look forward to continuing to monitor the data and share with others what we see. Eric?
Yes, and I'd also like to thank Hfma for having us on the webinar today, as well as Ensemble. Working with them, we've gotten to know the folks at Ensemble a lot closer through this analysis, and we have what we show today is recovery is beginning, and it's going to be a long road that we're going to go through, and as Peter indicated, we're going to continue to look at the data and bring back new analysis as we go through this recovery period. So thank you very much.
We have reached the conclusion of today's webinar presentation. I would like to thank our speakers for presenting and Ensemble Health Partners for sponsoring this timely presentation. We hope you have found the presentation informative. If you have questions about this webinar, you may email them to HFMA's Resource Center at resourcecenter@hfma.org. Our Resource Center staff will assist with questions not answered during this webinar. Please be sure to sign up for upcoming webinars via the website at hfma.org. Thank you for participating and have a great day.